Welcome to the audio digest of the American Journal of Psychiatry. This is Dr. Susan Schultz with highlights from our June 2010 issue. Treatment and outcome are featured in several articles this month. Our treatment and psychiatry case vignettes demonstrate the use of medications for 3 different types of alcohol dependence. We'll also report a clinical trial of treatment for comorbid alcohol dependence and depression. The combination of sertraline and naltrexone was compared with the individual drugs and placebo. 2 treatment articles on schizophrenia relate to antipsychotic medications. The first one presents a trial of risperidone for maintenance treatment. The second one reports recommendations for antipsychotic dosing based on expert consensus. The next study examined outcomes rather than treatment for borderline personality disorder. A 10-year prospective study tracked remission and recovery in a group of hospitalized patients. Another theme this month is the response to trauma, and we'll conclude with a review of the evidence for a dissociative subtype of post-traumatic stress disorder. We'll begin with treatment in psychiatry. Bancolay Johnson describes medication treatment of different types of alcoholism. Without a pharmacological adjunct to psychosocial therapy, alcohol dependence is likely to have a poor outcome. The choice of pharmacotherapy can be based on the subtype of alcohol dependence. One type is characterized by onset before age 25, high familial loading, and impulse discontrol. In contrast, late-onset alcoholism is characterized by a preponderance of psychosocial morbidity and low familial loading. The more promising agents for the reduction of heavy drinking or prevention of relapse appear to be ones that modulate the corticomesolimbic dopamine system through the opioid, glutamate, GABA, or serotonin system. How to treat different types of alcoholism is illustrated by 3 case vignettes. The first one represents chronic alcoholism. The patient's a 55-year-old man who complains of headaches that start soon after he awakens and are usually relieved by eating breakfast. He's been married and divorced 3 times and says he likes to hang out with his buddies on the weekends. He estimates that he drinks more than 2 six-packs a day from Thursday to Sunday, and that this pattern has continued since he left high school. He denies that he gets drunk, but he received a citation for driving while intoxicated. In addition, he's obese and hypertensive, and he has elevated liver enzymes and cholesterol. The first step in treatment should be to negotiate a drinking goal with the patient. While the gold standard is complete abstinence, some patients are helped by setting increasingly lower levels of drinking. Given the severity of this patient's alcohol dependence and the medical complications, topiramate may be one appropriate medication. It's excreted mostly unchanged by the kidneys, so there's less risk of worsening his developing liver impairment. Topiramate's been shown in 2 large clinical trials to improve all drinking outcomes. It's also been shown to decrease related medical consequences, including obesity, hypertension, liver abnormalities, and high cholesterol. Topiramate should be started at a dosage of 25 milligrams per day and titrated over 8 weeks up to 300 milligrams. Efficacy appears to be evident at doses as low as 100 milligrams, so titration can be stopped at this point if tolerability is a problem. A brief psychosocial intervention should be administered weekly. The next case vignette is an example of late-life alcoholism. The patient's a 66-year-old single retired teacher who says she often feels gloomy. She has few friends, and the recent financial crisis has caused her to lose most of her pension. She's considering a return to work, but she's pessimistic about her prospects. She drinks a nightcap and a morning pick-me-up, and with lunch and dinner, she usually has 2 to 3 glasses of red wine. Her sleep is disturbed by early awakening, with difficulty returning to sleep, and she occasionally has headaches in the morning. Every clinician should inquire about drinking habits in the elderly. Because alcohol dependence is related to morbidity and mortality in this age group, the practitioner should negotiate a goal or a sequence of targets that culminates in abstinence. The patient's age might make her prone to forgetfulness, and she's relatively isolated, and so one appropriate pharmacotherapy would be injectable extended-release naltrexone. The first dose would be administered after 3 to 5 days of abstinence, which might require supportive benzodiazepine treatment. The patient could then receive an injection of 380 milligrams of extended-release naltrexone. This would be given monthly for a total of 4 months. At this time, an antidepressant wouldn't be appropriate. The patient doesn't meet the criteria for major depression, and her reported gloominess is likely to lift as her drinking decreases. In addition, SSRIs have mainly shown added benefit for comorbid alcohol dependence and depression when the dysphoria is marked and suicidal ideation is present. Also, the patient's age at the onset of problem drinking would have to be determined more accurately, because SSRIs can trigger an increase rather than a decrease in alcohol consumption among late-onset alcoholics. The third case of alcoholism involves a college student who's seen in the emergency department after falling off his bicycle, which happens frequently. He says that he only drinks on weekends with others, but acknowledges that he shares multiple kegs with 3 friends. He also admits that on Mondays he often doesn't attend morning classes. He sometimes smokes marijuana with his friends. He started to drink when he was 16, and he reports that his mother and an older brother have attended Alcohol Anonymous meetings. The first step in treatment should be to educate the patient about the health problems related to alcohol dependence and sensitize him to his risky behaviors. In this age group, goals typically focus on reducing heavy and binge drinking. One medication for this patient would be ondansetron, a serotonin 3 antagonist that's been shown to improve drinking outcomes in patients with early onset alcoholism. However, it's not currently available commercially at the therapeutic dose for alcohol dependence. An alternative would be naltrexone, which has been approved by the FDA for alcohol dependence. The therapeutic response appears to be greater among patients with a family history of alcoholism. The dose should be increased up to 100 milligrams per day after the patient has been abstinent for 3 to 5 days. Treatment should be continued for as long as possible, at least 2 months. Disulfiram is another FDA-approved medication, but its efficacy appears to depend on having a partner to ensure that the patient complies with treatment. Furthermore, it doesn't reduce the urge to drink. Acamprosate has also received FDA approval for alcohol dependence, principally on the basis of European studies, but 2 large double-blind U.S. studies have cast doubt on its efficacy. All 3 patients described here can be managed successfully by non-specialist practitioners in an office-based practice. Detoxification can usually be done on an outpatient basis. Hospital admission should be considered only in extreme cases, such as for patients with a history of seizures, delirium tremens, or serious medical complications. Alcohol dependence carries a significant risk for development of major depression and vice versa. Helen Pennati and colleagues conducted a double-blind, placebo-controlled trial combining sertraline and naltrexone for treating co-occurring depression and alcohol dependence. The evidence for the efficacy of antidepressants in alleviating depressive symptoms in alcohol-dependent patients is limited, and the results are contradictory. In addition, antidepressants don't appear to affect drinking in depressed alcohol-dependent patients. Thus, a medication that directly affects drinking may be necessary. Naltrexone is approved by the FDA for alcohol dependence, and Pennati and colleagues examined the combination of naltrexone and sertraline in a double-blind, placebo-controlled study. The participants were 170 men and women with current diagnoses of major depression and alcohol dependence. They were randomly assigned to naltrexone only, sertraline only, the combination, or placebo. In both the combination and naltrexone monotherapy groups, the dose of naltrexone began at 50 milligrams a day and was increased to 100 milligrams over 1 week. In the next week, patients who were assigned to combination treatment or sertraline monotherapy began receiving 50 milligrams of sertraline per day. This was gradually increased to 200 milligrams, but flexible dosing was allowed for patients who couldn't tolerate the maximum dose. Treatment also included weekly individual cognitive behavior therapy using a version adapted for both alcoholism and depression. Over the 14-week trial, patients attended an average of 8 CBT sessions. The modal daily medication doses were 91 milligrams a day of naltrexone and 170 milligrams a day of sertraline. There was no significant group difference in medication adherence, which was 87% overall. Approximately 43% of the patients prematurely discontinued treatment, but there were no significant differences across the groups. In the group receiving sertraline plus naltrexone, 54% were abstinent for the 14 weeks of treatment. The rate for the other 3 groups combined was 24%, which was significantly lower. There was also a significantly longer time before relapse to heavy drinking in the group receiving sertraline plus naltrexone. The median for this group was 98 days, compared with 26 days for the other treatments combined. In addition, there were relatively dramatic differences in response early in treatment between the group receiving combination treatment and the other 3 groups. Although a response before 2 weeks isn't typical for an antidepressant mood response, little is known about the time it may take for a change in drinking behavior in depressed, alcohol-dependent patients taking antidepressants. 2 depression outcomes were examined: the percentage of patients not depressed in the last 3 treatment weeks and the score on the Hamilton Depression Scale at the end of treatment. Although the results on both measures favored the group receiving combination treatment, the differences fell short of significance. No deaths or serious medical conditions occurred. The rate of serious adverse events was 26%, with the most frequent of these requiring inpatient detoxification or rehabilitation. The rate of serious adverse events was significantly lower in the group receiving sertraline plus naltrexone relative to the other 3 groups combined. There were no statistical group differences in the rates of adverse events considered severe or very severe. Now we'll turn to our reports on antipsychotic treatment. First is the randomized controlled trial by Tuan-Yui Wang and colleagues of risperidone maintenance treatment in schizophrenia. It's long been believed that antipsychotic doses can be reduced during the maintenance period of treatment, but systematic studies of how long the initial dose should be given are lacking. Also, in recent years there have been suggestions that the initial therapeutic dose of antipsychotic drugs, especially atypicals, should be maintained in the long-term treatment of schizophrenia. In one group, the optimal therapeutic dose of risperidone given in the acute phase was given for 4 more weeks and then followed by a 50% reduction, which was maintained until the end of the study. In the second group, the initial optimal dose was given for 26 weeks and then followed by a 50% reduction. The third group continued to receive the initial therapeutic dose. The study was conducted at mental health centers across China. The patients had been stabilized for 1 to 2 months after an acute episode of schizophrenia. They were randomly assigned to the 3 treatment groups, and each group contained more than 100 patients. At baseline, they were taking 4 to 8 milligrams of risperidone per day, and the mean dose was 4.3. This falls within the range recommended by Chinese guidelines, which is 2 to 6 milligrams a day. However, the Chinese standard is lower than the recommendation for Caucasian patients. In the 2 groups that received dose reductions, the dose was decreased by 0.5 milligram every 7 to 10 days, depending on the starting dose. It was reduced to 1/2 of the therapeutic dose over 8 weeks, which was maintained until the end of the study. Outcome measures were assessed monthly during the first 6 months and then every 2 months until the last enrolled patient completed the study. Treatment continued until the last recruited patient completed a 1-year follow-up, which meant that the first patients enrolled were followed up for 26 months. For the 4-week, 26-week, and no-dose reduction groups, the rates of study discontinuation were similar and ranged from 15 to 24%. There was a difference in the relapse rate, however. Survival analyses estimated the relapse rate for the patients receiving no-dose reduction to be 9%, compared to 31% for the group with a reduction at 4 weeks, and 20% for the group with a reduction at 26 weeks. When covariates were controlled, the time to relapse was significantly longer for the no-dose reduction group than either of the groups with reductions. Outcome was also assessed in terms of symptom scores. By the end of the study, the changes in the total score on the positive and negative syndrome scale and the scores for positive symptoms, negative symptoms, and excitement and hostility had improved more in the group with no dose reduction than in the other 2 groups. First episode schizophrenia patients generally require lower doses because they're more sensitive to the effects of antipsychotics than are chronically ill patients. Multiple logistic regression analysis was performed with the assumption that chronicity of illness would significantly influence relapse prevention. This hypothesis wasn't supported by the results of this study, however. Also, the proportions of patients with extrapyramidal side effects and other adverse events did not significantly differ among the 3 groups. Reduction in the dose of conventional antipsychotics in the maintenance treatment of schizophrenia is justified as an attempt to reduce dose-dependent side effects. The rationale for dose reduction of second-generation antipsychotics is less clear. Lower doses of risperidone are expected to mitigate the side effects related to weight gain and elevated prolactin levels, but in this study no significant differences were observed among the groups in weight gain or the frequency of prolactin-related adverse events. Antipsychotic doses for Asian patients were one aspect of the international consensus study of antipsychotic dosing reported by David Gardner and colleagues. In addition to recommended doses of a variety of first- and second-generation antipsychotics, experts were asked how these doses should be modified for specific subgroups of patients. The dosing guidelines currently available rest on a severely limited research base. This study used a Delphi method of consensus building in a broad 2-stage questionnaire-based survey of research and clinical experts. This method is used extensively in social sciences and health research, including mental health. It provides for independent input by each participant at 2 stages, with summary information included at stage 2, based on the average collective contributions from stage 1. Participants with experience in clinical research and clinical use of antipsychotic drugs were sought through literature searches, peers, and investigator consensus. Efforts were made to include geographically and demographically diverse participants. Research experts were considered eligible only if they had at least 5 peer-reviewed publications related specifically to clinical trials of antipsychotic drugs. Clinical experts were referred by participating research experts as particularly knowledgeable in the use of antipsychotics with extensive clinical practice experience. The survey instrument included 3 sections on clinically equivalent doses, dosing recommendations, and dosing adjustments for specific circumstances. In the first section, the participants estimated the clinically equivalent doses of 59 antipsychotics, including 36 orally administered agents and 13 short-acting and 10 long-acting injected agents. Clinical scenarios used olanzapine at a dose of 20 milligrams per day as the reference treatment for the equivalency estimates of the oral and long-acting injectable agents. Dosing ratios to this dose of olanzapine and to the equivalent dose for chlorpromazine were calculated as a historical reference. Injectable haloperidol at a dose of 5 milligrams was the reference for short-acting injectable agents. Study participants also rated their confidence at each estimate, high, moderate, or low. They were instructed to give priority to efficacy over tolerability in their dosing estimates. The second section of the survey requested usual starting dose, typical target range, and usual maximum dose for each oral or injectable agent. Brief, standardized vignettes provided a consistent context for responses. Typically, the vignettes were based on treatment of an adult man with schizophrenia who had at least 2 years of lifetime exposure to antipsychotics and was not considered treatment refractory or intolerant. The third section of the survey sought dosing recommendations based on variance in demographic and clinical circumstances. The participants were sent the same survey instrument electronically in 2 stages in accordance with the iterative Delphi method for consensus building. 43 completed both stages. They were from 18 countries, mostly in North America and Western Europe. Effectiveness of the 2-stage Delphi method was indicated by decreases in the variance of dose estimates between survey stages and by achieving an average rate of 76% consensus in the final clinical equivalency estimates and 67% for all dosing recommendations. Clinically equivalent antipsychotic dosing recommendations were obtained for 36 oral agents, 13 short-acting injectable agents, and 10 long-acting injectable agents. For oral antipsychotics, the overall median starting dose in olanzapine equivalents was 4.8 milligrams per day. The overall target range was 10.2 to 25.5 milligrams, and the overall medium maximum was 30.9. Several patient characteristics did affect dosing recommendations. Age had a major effect in that recommended median daily oral antipsychotic doses were 60% lower in children and 50% lower in the elderly. Selected medical comorbidities such as diabetes and heart disease also led to lower recommended doses relative to adult patients without such illnesses. The respondents recommended an average of 20% lower daily antipsychotic doses for East Asian patients relative to Caucasian patients. Now we'll switch to outcomes for borderline personality disorder. Mary Zanarini and colleagues tracked the time to attainment of recovery from borderline personality disorder and stability of recovery in a 10-year prospective follow-up study. 3 different outcomes were examined. The first was remission, which is defined as no longer meeting the criteria for borderline personality disorder for at least 2 years. Sustained remission was defined as not meeting the diagnostic criteria for at least 4 years. Recovery was defined as having a total score of 61 or higher on the Global Assessment of Functioning, having at least one emotionally sustaining relationship with a close friend or life partner or spouse, and being able to work or to go to school consistently, competently, and on a full-time basis. All participants were initially inpatients between the ages of 18 and 35. They were followed up in 5 waves, 24 months apart. Psychosocial functioning, treatment utilization, and Axis 1 and 2 psychopathology were reassessed via interview. Approximately 250 patients completed all of the follow-up interviews. At the end of 10 years, 93% of the patients had attained symptomatic remissions of at least 2 years, and 86% had remissions of at least 4 years. However, only 50% were judged to be recovered in terms of social and vocational functioning as well as diagnostic criteria. Of those who were considered recovered, about 34% returned to unrecovered status during the follow-up. The percentage was similar for those who achieved a 2-year remission of symptoms, but the recurrence rate was only 15% for those who achieved a 4-year sustained remission. Taken together, these results have implications for the treatment of patients with borderline personality disorder. Clinical experience suggests that the psychosocial deficits of these patients are rarely the focus of treatment. Rather, the emphasis is on symptom reduction and management. Those treating borderline patients might therefore want to consider a rehabilitation model of treatment for these psychosocial deficits. This approach could be an added component of treatment that doesn't directly compete for primacy with a treatment focused on symptom remission. We'll conclude with a discussion by Ruth Lanius and colleagues of emotion modulation in PTSD, clinical and neurobiological evidence for a dissociative subtype. They point out that emotion dysregulation in PTSD can take the form of either under or over-modulation in response to trauma-related information. These responses correspond to 2 subtypes of PTSD, one with re-experiencing and hyperarousal, which is more common, and another one with dissociative symptoms. These 2 subtypes appear to have distinct CNS correlates. In one study, when patients with PTSD were exposed to reminders of traumatic events, approximately 70% had an increase in heart rate and the subjective experience of reliving their traumatic experiences. The other 30% had a dissociative response that involved subjective states of depersonalization and derealization with no significant increase in heart rate. The 2 states also show opposite patterns of brain activation in regions that are implicated in arousal modulation and emotional regulation. In particular, these differential patterns are found in the medial prefrontal cortex, anterior cingulate cortex, and the limbic system. In response to trauma reminders, the subgroup with hyperarousal and re-experiencing has abnormally low activation of medial anterior brain regions, including the medial prefrontal cortex and anterior cingulate cortex. This is consistent with failed inhibition of limbic reactivity and is associated with emotional undermodulation. In contrast, in the dissociative subtype, activation of medial prefrontal structures is increased, which is consistent with hyperinhibition of those same limbic regions. Further support for the corticolimbic inhibition model comes from studies of correlations between the severity of re-experiencing and brain activity in regions associated with awareness and regulation of arousal and emotions. The processing of fear and pain in patients with PTSD also adds to the evidence, as does the association in healthy subjects between suppression of emotional memories and bilateral hippocampal inhibition. The neurobiological findings are consistent with the phenomenology and clinical presentation of patients with dissociative PTSD. Many of them require therapeutic approaches that help them overcome pathological overmodulation of traumatic memories, associated emotions, and bodily experiences. Individual patients may show both under and overmodulation of affect and response patterns, either simultaneously or at different time points. However, those with prolonged traumatic experiences, such as chronic childhood abuse or combat trauma, often exhibit chronic and frequent symptoms of dissociation as opposed to patients who have suffered from more acute forms of trauma. Research also indicates that trauma experienced earlier in life creates a significant dissociative component to later PTSD. Differentiation of PTSD subtypes has implications for both research and treatment. Exposure-based treatments involve repeated imaginal and in vivo exposure to trauma-related stimuli, and for them to be successful, patients must be able to fully engage emotionally with the trauma-related information. However, exposure treatments should be used with caution in patients with significant emotional overmodulation. It's been suggested that these symptoms can prevent emotional engagement and reduce treatment effectiveness. In fact, a recent study suggests that levels of dissociation are the most important negative predictor of psychotherapy outcome in patients with borderline personality disorder, which has often been associated with childhood abuse. Before starting exposure-based treatments for PTSD, it's crucial to assess the level of dissociative psychopathology and provide interventions to reduce dissociative responses to trauma-related stimuli. Failure to do so can lead to an actual increase in PTSD and related symptoms. One group of researchers developed an intervention that's given in phases for long-term PTSD related to child abuse. The model accounts for the significant dissociative symptoms frequently associated with repeated childhood maltreatment. It's delivered in stages and uses skills training in emotional regulation. Before engaging in exposure-based therapy, patients develop mood regulation and grounding skills, identify and modify disordered attachment schemas learned in childhood, and work on competence in social interactions. This concludes the audio highlights of the June issue of the American Journal of Psychiatry. We invite you to our website, ajp.psychiatryonline.org, for the full text of these and other articles, including author affiliations and financial disclosures. We also welcome comments regarding this audio. They can be emailed to Jane Weaver. Her email address is jweaver@psych.org. Next month, our audio will highlight treatment of obsessive-compulsive symptoms in schizophrenia, approaches to treatment-resistant depression in adolescents, maintenance treatment of bipolar II patients who respond to an antidepressant, and the NIMH research domain criteria. We hope that you'll join us. Thank you.